we're glad to have you join us. This is Platform. I'm Ruth Aguilera. Motherhood is a gift, and no woman deserves to die while given life. Now, this is why maternal health plays a critical role in shaping the future of any society. Before now, the alarming rate of maternal mortality and child mortality in Nigeria used to be overwhelming. But following interventions by the present administration, reports by the Federal Ministry of Health and Social Welfare state there's been 17% reduction in maternal death and a 12% decline in newborn death across 172 high-burden local government areas. And recently, Nigeria joined the rest of the world to mark Safe Motherhood Day with a clarion call towards ending preventable maternal and newborn death, which is no longer optional, but it is a shared responsibility and a national priority. Safe Motherhood has been adopted in the country through various initiatives we've seen, like the Maternal and Neonatal Mortality Reduction Innovation and Initiative, MAMI, which is currently implemented in 32 states. MAMI focuses on improving service delivery, emergency obstetric and newborn care, and of course referral systems. Now, the federal government has reiterated its commitment to improving maternal and newborn health outcomes, stressing the need to move beyond access to ensuring quality, timely and equitable care for women across the country. But the focus remains on strengthening healthcare access and ensuring that no woman is left behind, especially in rural and undeserved areas where medical resources can be limited. But the question is, how can this progress be sustained in the aspect of inclusive and accessible maternal health care across the country? So our focus will be on promoting safe motherhood in Nigeria, and our guest is Dr. Abdulhadi Dio Saidu. He's a consultant, obstetrician, and of course a gynecologist, and head Safe Motherhood branch from the Federal Ministry of Health and Social Welfare. Thank you very much for joining us, Dr. Saidu.
Thank you for having me, Ruth.
Good to have you here. And our panelists on platform today will be one of our health correspondent, Elizabeth Omoyi. Elizabeth, this is your first time on platform. I was so pleased to have you here.
Of course. Thank you so much for having me.
Great. So, Dr. Saidu,
Yes.
I know there's a lot when it comes to when we're thinking of maternal health in Nigeria, especially with the burden, which we're seeing the decline in the numbers for Nigeria. But as a gynecologist, I'd like you to just break it down for us. When someone is thinking safe motherhood, what are the areas of concern, especially what goes on behind the scene during pregnancy and during childbirth for a woman?
All right, thank you very much. When you say safe motherhood, it entails all of those measures that are taken to ensure that a woman goes through pregnancy, childbirth, and of course in the postpartum period, healthy, with also having to have a newborn who is also healthy. So simply we can put safe motherhood at that a woman going through pregnancy, childbirth, and the postpartum period in a good state of health, including having a newborn that is healthy without any serious complications. So we have what we call pillars of safe motherhood, which are things that entails this. Although there have been several modifications, but core to this, we have family planning.
Yeah.
If a woman is not ready to become pregnant, or her body is not ready to become pregnant, she needs to be on contraceptive, or she needs to practice family planning. And when she's ready and she's become pregnant, antenatal care is very key. This is when the pregnancy, both the mother and the baby unborn, are actually monitored to ensure that they are both healthy. And if there are challenges along the way, these are detected early, and measures are also taken. Next is care during delivery, and this is where most of the problems happen. Most complications happen during delivery, and this is very key. Interventions at this level are also very key. Then in the postpartum period is another pillar, Often we hear, oh, people are celebrating, families are celebrating their baby has been born.
What about the mother?
Exactly. So things can happen after delivery. Even the baby, things can happen after delivery. So it's also a critical period. Then we also have issues around miscarriages and abortion, which is also a major cause of maternal death. Then we have sexually transmitted diseases, including HIV. Then we have also issues that are cross-cutting. Things like maybe communication, issues around primary health care, things that maybe equity for women, including education. These are things that
Access
actually...
to information.
Yes, these are things that determine safe motherhood. So in simple terms, we can say this is what safe motherhood is all about.
Elizabeth, I'm sure you want to come in there.
Of course. I'm happy you highlighted the pillars for us and you explained them. Now let's talk about closing the gaps from coverage to care for every Nigerian woman out there, which is actually part of the national priorities. Now, would you say Nigeria has made measurable progress in helping women access these care we are talking about, from pregnancy to delivery?
Yeah, you've just mentioned the theme for Nigeria celebration of safe motherhood this year, commemoration of safe motherhood this year, which is closing the gap from coverage to quality care. You know, over the years, a lot has been done to ensure that women have access to care. However, we understand that access alone is not enough.
Okay.
The quality of the services you get actually determines who survives, because some women still get to the facility and end up dying. So that is why we are also looking at not just coverage, not just reaching to where you get care, but what is the quality of the care that you're getting. So we're also trying to, it's not that it's been neglected before, but we're also trying to come strong in the area of quality care. So that's what informed this year's theme for Safe Motherhood commemoration.
Okay, and during that commemoration, we've had the ministry come out to say there's been improved new clinical protocols. We're seeing improvement in skilled birth, especially for women in rural communities. But tracking the numbers and looking at the demand and the burden or the challenges of infrastructure in primary health care centers at those hinterlands, it has been a major gap, has been a major challenge, and also access to that universal health coverage to help women have access to emergency responses in terms of childbirth. What is the ministry doing, you know, to close those gaps in that regard?
Yeah, thank you very much. You know, there is what we call the delays.
Yeah.
The first delay, which has to do with the patient, her family, and the community. How quickly are they able to make decisions to go to access health? Then we have the second delay, which has to do with the transportation to reach where they will get the help. And we have the third delay, which has to do with the facility itself. When the patient get there, how quickly are the health workers able to provide the care that they need? So when you're talking about access, what we are talking about now is how do we overcome that second delay? And this is one of the key areas that we've made significant stride in the recent years. We have what we call the National Emergency Ambulance System. It has been there for quite a while. However, there has been a revamping of that program in recent times. And again, we also have the rural component of it, which is called Rural Emergency Services and Maternal Transport, because we understand that big ambulances, vehicle ambulances may not be able to get to such areas. So we make use of what is available, such as tricycles. And we've made it in such a way that the community are well involved. We have focal persons within the ward, within the World Development Committee. When there's an emergency, when a woman is in labor, when there's complication, they call that number, and that number triage now send message to a commercial transport worker, of which pre-arrangement has been made, and that patient is transported to the nearby facility where help can come, and the government reimburses
So it's
the
free?
driver. It's free.
Oh, okay.
It's free. So it has commenced, and I tell you that out of the 172 MAMI LGS, over 162 or so has been, this system is working in those local governments.
And you then respond to the part of the infrastructural gap in the primary healthcare centers.
Yes. Nigeria is a developing country, so like other developing countries, we have gaps in terms of infrastructure. However, the government is also doing a lot now to fix that. The PHC revitalization is currently ongoing, and as of today, I think over 8,000 PHCs have been revitalized. And the target is to get up to 17,000,
Yeah.
having up to 2 PHCs per ward, and that's the target. This is a joint venture between the federal government and the states. So we are in this together, both at the federal level and at the state level.
Okay.
All right, let me come up with the issue of NEMSES. You mentioned rural areas where these women are. Many of them call for the ambulances and then they get there. Some in good time, some not in good time. But there's a particular issue. Let's debunk the myth. Some persons do not actually use the ambulances when they're supposed to. They do not allow themselves to be taken in an ambulance to the hospital. Why? Because it is believed that corpses are carried with the ambulance. So how do we debunk this myth around ambulances and pregnancy? Because it is believed that a new life is coming. So why should you convey a pregnant woman in an ambulance? So we need you to clear that aspect for us.
Especially what the ministry is doing to sensitize the people.
Mm-hmm.
You know, we're in Africa, a lot of myth
Indeed.
is there, and again, in health sector too.
It's a lot.
A lot of them.
Mm-hmm.
So that's why we have a division that is saddled with that responsibility to do that. And even at that, they are not the only one doing it. Any health worker is expected to know how to debunk some of these myths and misconceptions. I think we cannot, when I was talking about pillars of safe motherhood, I talked about communication for behavioral change as one of cross-cutting issues for pillars of safe motherhood. This is very, very, very important. In the MAMI project, we have the advocacy aspect of it, which cut across so many levels. Community gatekeepers, religious leaders, traditional leaders, women group, youth group, it cut across all of this. Then even the health workers, we continue to train them on how to pass information. Even if you are working within a community, even though you're in a facility, you also have a responsibility to carry the message to the community that you serve. And again, at state level, radios, televisions, we also do that. But we think it is more effective when we go through stakeholders within the community, and that is what we are doing. And sometimes the main generator of demand is providing quality. If someone is sick and is taken with this ambulance and the person comes back healthy with her baby, I think that's enough
Conviction.
Yeah, exactly,
yes.
advocacy for you to know that this works. So for those who decide to stay back and something adverse happens, you may not want to do it next time.
At all.
So I think it's also upon us for us to ensure that this system works. When this system works, it will drive demand on its own because people will see the results.
Yes. Okay, I'm sorry, let me just come in there. Recently there was a ministerial briefing on safe motherhood, and 6 documents were actually unveiled. I'll just read them out to you. Maternal and Newborn Product Introduction Plan, the Obstetric Clinical and Newborn Service Protocol, the Life-Saving Skills and Expanded Life-Saving Skills document, the MAMI document, and the revised antenatal care guidelines aligning with global best practices. Now, these documents, how do they work? We need you to break it down for the Nigerian woman out there.
Okay. Let me say, most of the documents, or all of the documents, the end users are the frontline health workers.
Okay.
However, there are some that are for decision makers, health managers, and all of that. Let me start with antenatal care.
Oh.
You know, health is a dynamic area. Medicine is a dynamic area that new evidence continue to come out. New ways of, better ways of doing things continue to come out.
Yeah.
And that's why we continue to review our guidelines. So we just reviewed this antenatal guideline, putting together some of the new ways of making things better. And this guideline is supposed to guide health workers on how to conduct antenatal care, what services to provide. There are certain things we were doing before we thought they were good. Now evidence is telling us that those are not the best ways of doing it. There are certain things we were not doing before. Evidence is now telling us that these are good things that we can do. So those are the things that are contained in the antenatal care guideline. And there's what we call it's for positive pregnancy experience.
Okay.
It's part of it, meaning women have to be part of their care. The perception of the women is put in the center of this, because often we give women care and we feel we are doing the best for them, they should just accept it. Now we want the women to feel that I'm part of this.
They own it.
They own it, and they are happy that I'm part of the decision of my care. So that's one key area that is part of this antenatal care guidelines. Then the second one, we have the obstetric and newborn protocol. It's just like a reference document that has the common conditions that a pregnant woman can have, common conditions that newborn can have. It's supposed to be like a reference document there in the facility. When maybe a young doctor, a young nurse is there in the facility and is faced with a case, can quickly go and look at it and say, okay, oh, this is likely what is wrong with this person, and these are the things I'm supposed to do. That is the protocol. Then we have the LSS and the ELSS. Those ones are for management of emergencies. When you are faced with maternal emergencies or newborn emergencies, what are the things you should do? That is what those ones are covering. They have the facilitator's manual and the participant manual. Then the other one is the MNH product introduction plan. Often people or partners bring in drugs, introduce it into the country, and it is not systematic. Sometimes you see certain medications are there, in the next 1 year they are not there, because most of these things are done in pilot formats. We have now said any medicine we are bringing in or want to introduce into the country for management of pregnancy-related issues or newborn, there should be a system that introduces it. This system will look at from beginning till the end. If we start this, we will be able to take it to the end. We'll be able to sustain it, so that it's not something that will come and we just we won't find it again. So how do we ensure that it gets to areas they are needed? It's not bringing it to Abuja City. Meanwhile, there are people in rural communities in Borno State who need this. So we need to look at all of this as a group, both government and partners, before we say, okay, this is how we're going to introduce these drugs. And of course, the MAMI manual is just to also guide both the federal and the state level on how they should go about in implementing MAMI. So
and it's good that states are already picking up with the MAMI
Yes,
initiative. We're seeing that in 32 states.
Exactly.
So I'd like a clarification for the nationwide expansion, which is part of the improvement we're seeing. The expansion scale of the comprehensive emergency obstetric and newborn care, which provides live treatment for pregnant women going through complications even after birth. is that being replicated? Because you just talked about not leaving it at the center, but decentralizing such initiatives. How are you equipping, or rather the ministry, how are they equipping health workers across board to ensure that they are well equipped? If these emergencies can be really comprehensive at the federal level, states level, what about rural communities?
The grassroots.
Yes. Actually, what we do here is developing policy documents, developing guidelines, SOPs, but the actual action happens at the state level.
So, to put it in a better context, is the ministry getting a feedback or the right synergy, from state governments to work hand in hand? Because they are the ones who will ensure that these health workers are equipped with the necessary tools they need to make this happen.
Okay. Maybe I'll start with, maybe at the beginning of this administration, there was some signing of compacts between the president and all the governors of the state. This was also midwifed by the coordinating minister of health. This is to bring about this synergy, for us to agree that we have common problems, and let's come together and prioritize our problems. And that we are going to agree on A, B, C, D, that we will all do this. State might want to add, depending on where you are. However, those ones that we have agreed to do as a country, we will do them together. And all the governors agree with that. And we also form coordination structures, technical working groups. And there's a specific technical working group that engage between the Federal Ministry of Health and the health sector within the states. That's at the strategic level. Then at programmatic levels, we also have this. For instance, if you are a reproductive health focal person at the federal, you have connection with all reproductive health officers across the states. And that is how you disseminate all the things you want to pass down. So, like I said, these guidelines, these documents are going to be used at that level. So dissemination, we ensure that we disseminate up to the last mile, and also follow up with a kind of supportive supervision, and to also follow up with, to ensure the M&E, to ensure that we are getting feedback from that level, because that's where the documents are going to be very useful.
We're good at having fantastic policies documented. Implementation is always difficult. It's always the problem.
Absolutely.
So, providing if you're giving a health worker a document to work with, and you're not giving the health worker the right tools to make that happen, so are there provision for the necessary tools?
Yes. 2, we've been conducting trainings, which is an ongoing thing. And now we're even adopting new ways of training. Usually we call people from different parts of the country to a particular location to conduct training. We have seen that that is not efficient. Now evidence have shown that when you train on site, in the facility, and you are doing it in small bits, they are more useful. And that's what we are adopting now. So we conduct, the initial one can be somewhere, but continuous training continue to happen in the facility. What we want now is for every facility to have what we call learning corner or training corner, where you can come in the morning and just go there and try your hands on some of those skills for you to perfect it. That is on the side of training. Secondly, massively, equipment have been disbursed to so many PHCs. I can't give you the exact number now, but I think at that press briefing the other day, the ED of NPHCD also spoke about the number of facilities that have been equipped. And when we say revitalization of PHCs, revitalization includes both infrastructure, equipment, and human resource. And we said we have revitalized over 8,000. It means both equipment, both human resource, and infrastructure have been put in place.
Okay, I'm going to check you back on the issue of MAMI guidelines. at a workshop recently where I attended, I actually attended a workshop recently, the issue of mommy and teenage pregnancy came up. Are teenagers covered within these guidelines when we talk about reproductive health? Because we can't take it outside.
Unwanted pregnancies.
Yes.
So when we say antenatal guideline, if you're able to read through it, you see that we're deliberate about adding adolescents. Okay. Previously, we do say pregnant women because we just assume that anybody who is pregnant can automatically become a woman. But we know they also have peculiarities. Yeah. So now we're deliberate, saying pregnant women and adolescents. Throughout the guideline, those are the phrases we're using. And the mommy intervention is for all pregnancies, all women and adolescents that are pregnant.
Okay.
And whether it's a teenage or an adult, this will cover you as far as you are pregnant. In addition, there are some other aspects of mommy that we're not aware of. Maybe issues like counseling, issues around family planning. These are things that are also there, and this is to prevent unwanted pregnancies. And when a woman becomes pregnant, of course, all the care that she deserves are all encompassed in the interventions for mommy. So there's no discrimination for using age.
Okay. Within that, I'm sorry, Ruth. Within that guideline, the mommy guideline, there's a particular segment, women with HIV. Does it cover these women?
Absolutely.
Okay.
Absolutely.
There's another aspect following the mommy, not just the mommy, but on a comprehensive scale, looking at it from a holistic view. Persons with disabilities, especially the deaf community, there's been concerns of them not having access to this information when they're in hospitals. They don't have sign language interpreters to explain to them you know, what is happening. Antenatal care is more of teaching these women for that long period of their pregnancy, and also for the blind, you know, the visually impaired. How are they, you know, assistive devices,
do they have them?
you know, to help aid this safe motherhood we're talking about?
Yes, you're very correct. But we also need to be realistic that we're coming from somewhere.
I understand.
Yes, yes.
I want to know if there are plans for inclusivity.
Yes, I'm coming there.
Okay.
We're coming from somewhere, and we hope to get there. For now, usually, in most cases, you see accompanying persons assisting. However, that might not be the best way for confidentiality. It is deliberate that we have a disability unit in the Federal Ministry of Health. And the unit is developing, and we hope they are already coming out with the policies. However, if you are talking about every facility having someone who can use sign language, someone who can communicate with someone who is blind, it's not
looking feasible.
Not for now. And again, this may not rest solely on health. We also have other ministries and agencies that also deals with issues around disability.
That's where I'm getting.
Shouldn't there be collaboration with the Ministry of Health and the National Commission for Persons with Disability?
Absolutely. That collaboration is ongoing depending on the area. For instance, in the issue of disability, our disability units collaborate with them. However, like I told you, even the ministry was formed just maybe like 5-6 years ago. So we don't expect them to be as established as maybe Ministry of Health also. But we have planned to get to where you're talking about, where we have these devices. Some of these hospitals, they've been built very long ago. Now we're talking about how can we have ramps that can
help them
access the building, all of this. So if you see newer facilities now that are being built, they put all of those into consideration. But there are some that have been there very long ago. So it's our hope that when we are revisiting those buildings, when we are restructuring those buildings, or we are rebuilding those areas, all of that can be put into consideration.
Okay, so just before we take a break, I would like the ministry, now this is a recommendation in the aspect of promoting that inclusivity. Just the way skilled birth attendants, have been inculcated into the system over time, even at the rural areas. There are people in communities who understand the sign languages. They can be worked with. There can be a sense of collaboration to have them at these primary healthcare centers so that no woman is left behind.
That's a recommendation.
Okay, you mean traditional birth attendants?
No, I'm talking about the way traditional birth attendants are gradually being recognized. This way, they also have, people in communities that understand sign languages and even, do the sign languages, which, they can be incorporated into the system for the rural communities, especially the primary health cares we're talking about.
Yeah, I agree with you. Like I said, we are working towards
Like
that.
I said, it's a recommendation.
Thank you.
Okay, so let's take a break, ponder on some thoughts. We'll be back just in a moment, so do stay tuned.
What are we doing as a nation to first of all settle our teeming populace, especially the
NTA's political package with a third eye on the nation's political scene? I am Fisa Ogunfuyi. Welcome.
You have to be very careful giving space to people who are obviously sponsored to further the agenda of some other groups.
There's a lot of questions. A lot of questions in a closed door sessions. Some of these issues, some of the problems bedeviling of their
In fact, between June 1st and July 17, 19-point-something billion has left the coffers of the NDDC.
I can say my constituency, they need everything because we don't have anything.
Platform.
MFA for digital literacy is a bot that you can use, you can interact to learn more about digital literacy.
Hello, it's our pleasure to have you join us on Platform. I'm Ruth Aguwele.
What is the yardstick for measuring everybody's moral integrity? It's critical at this point in time.
How daunting has that been for the Institute in getting them abreast with all the legislative procedures?
The fact remains that one training workshop is not enough.
Thank you for staying tuned. The conversation is on ways to promote safe motherhood in Nigeria. And we have Dr. Saidu. He's a gynecologist and, of course, head Safe Motherhood from the Ministry of Health and Social Welfare. Elizabeth, you were going to pick up with a question.
Yes, and I'm happy he's a medical practitioner. Now, let's talk about the attitude of your workers, your colleagues in our hospitals. For example, Ruth mentioned earlier, a visually impaired woman walks into the hospital, she's having complications, she can't see. Or someone that can't hear, she can't hear, nobody's interpreting with the fingers. She cannot explain what is happening to her. But the other person is normal. The doctor is normal, the nurse is normal, the midwife is normal, every other person normal. Now, the attitude of our health workers towards persons with disabilities has to change. So how do we correct this narrative? Because many of them are losing their babies, some lose their lives, some just go because they are frustrated. They can't talk, they can't see. Families are not helping them. So how will the society or the government help them if they can't help themselves? So how do we walk out of this narrative?
Thank you very much. I would say you're talking about respectful maternity care.
Yes.
And we don't limit this to
dignified care
to only persons with disability. Even someone without disability, you want to be treated well. Often you see some persons, you say, oh, I won't go to such facilities again.
Because of their attitude.
Yes,
attitude of
attitude
certain person.
yeah.
So we understand that. So it's not just persons with disability. And let me come back to the theme of this year again, closing the gap from coverage to quality care. When you say quality care, it involves two sides, the provision of care and the experience of care. So what you are talking about is experience of care. The person receiving the care, how has that person perceived that care? And under experience of care, communication is one aspect. Respectful maternity care is one aspect of it. So it is something that we are very deliberate about. So this theme, we are not just using it because we want to use a slogan or a theme, but it's something that we want to deliberately want to close the gap. We understand that such attitudes happen, not just in Nigeria, but if it's only in Nigeria, it won't be a global thing, because respectful maternity care is a global thing. So we have accountability mechanisms that we have put in place to ensure that such issues are detected. I don't know, there's what we call MPCDSR, Maternal, Perinatal and Child Health Surveillance System. We also have quality of care programs, and these are accountability mechanisms that have been put in place for us to ensure that we tend to change the attitude of health workers, putting all of this in training so that they understand. Sometimes a patient can do something that you don't feel happy about, but you just have to be happy with it.
Absorb it.
You have to absorb it because you are in a position, you are in a position that of advantage over her. So it's important that we're able to tolerate it's just like a business person who has a client. Your client is always right. So, and that is what we are also looking at, that as much as possible, we need to treat our women with respect, with dignity, and that is why now, in our current guideline for labor care, companionship is a major issue. In fact, you have a red, in your documentation, you have a red mark if you don't have a companion, because we think it's something that is very important. Issues around, want to stop the situations we used to see before. When women are in labor, we are hearing shout everywhere. We want to make labor more comfortable so that analgesia, pain relief, is something that is we want to give liberally as far as it's safe and as far as the woman requires.
At subsidized rate or for free?
It depends on where you are accessing your care.
Okay.
If you are accessing your care where the services are free, you get it free.
Okay.
But you don't expect government, don't expect to go to a private facility and you expect government to follow you there to come and
exactly,
pay for you.
Which brings me to this question of the universal health coverage, especially for maternal care, the expansion of it. I know there are a lot of gaps in that regard, even for other care, other services. How is the ministry ensuring that it narrows down to ensuring that all areas, no matter the complications, women are covered in that aspect?
Sorry, come again with the question.
The universal health coverage
Okay.
expansion.
Yes.
How is the ministry ensuring that for maternal health, it's a comprehensive package?
Yes, for maternal health, you know, there are, even though I don't work with NHIA, but there are different ways people can be enrolled into that. For those who are working in formal sector, it's quite easy to do. However, we also have private companies also making arrangements for their own packages too. The issue is the person who doesn't work with any of this. And we also have state insurance agencies, and where people come together in the community, they come together and organize themselves and are able to do this. It is work in progress because there has been significant increase in the enrollees. I think over 21.7 million people are now enrolled. Within the last 3 years, I think from around 16 to 21.7. So there has been significant increase.
So Dr. Saidu,
Yes.
you know why I asked that question? You were talking about the anesthesia that people can, you know, have,
Yes.
which cannot even, it depends on where you're receiving care. That would determine if you're getting it for free or at subsidized rates.
Yes, yes.
Now, there are areas of concern under the universal health coverage where people still pay monies for certain services that are supposed to be covered. I want to know, as the head of the Safe Motherhood under the ministry, NHIA is under the ministry's purview. So how are you also promoting, since you say it's work in progress, are you also pushing that all aspect of it when it comes to maternal care, comprehensive package, is guaranteed for every mother expecting a child?
So, like I said, it's a gradual expansion.
Okay.
Wherever it has reached, any facility it has reached, the coverage is comprehensive. We don't leave anything, in as much as those services are available within that facility. But if those services are not available within those facilities, they may have to go to the next level of care. And if we are able to, if it's an area where the emergency ambulance services is also functional and they are transported to the next level, that is also taking, the care within the first 48 hours is also taken care of by that system.
Okay.
Okay, I'll just quickly share a story with you on comprehensive emergency obstetric. Years ago, I was in a government hospital in Zamfara State, and a woman came into the hospital to deliver, but unfortunately, the baby died before she got to the hospital. And then they kept waiting for her husband to come in, put pen to paper, sign, and then she could be pushed in. Her husband refused to show up. So it took a very long time before she agreed that the baby should be evacuated from her, and then the doctor actually did later after a few hours. Now, I understand that comprehensive emergency obstetric care is not cheap. Let's leave the financial aspect aside. How do we build on education for men, society, and culture? Because just a little thing could kill a mother and her child.
You're very correct. Health education is a major chapter in our new ANC guideline.
Okay.
And in there we have the role of male involvement. We have role of family involvement, the role of the community, because we think these are key areas that nothing else can replace them.
At all.
So we encourage men to be involved in the health of their spouses. And in the guideline, questions will be asked about, even if we encourage men to follow their women to facilities. But where they are not there, we also ask, these things we are doing for you, is your husband aware? What is his perception about it? So that if there is need for us to also invite the spouse for us to speak to them, we also do that. We also have support of family. That is also very important. So we also try to know what is the setting within the family and the extended family. Can this family support this woman throughout this period of pregnancy and delivery? And if we sense that there could be something off, we also try to see how we can resolve that. So it goes from just clinical care. We're also moving to social aspect of it, because all this will contribute to the outcome we desire to have. So these are some of the things we are looking at, not just...
All right, I'm sorry, this is just on a lighter note.
Yeah.
Why do men actually shy away from obstetric responsibilities?
As a man.
As a man. I'm asking because you're a man.
No, but he's even a doctor.
I'm a doctor.
Yes, I'm a man, but if you sample different men, you see that our orientations are different.
Okay.
Yeah. So maybe traditionally, you feel pregnancy is the business of a woman.
But he got me pregnant.
The business,
exactly.
But he got me pregnant.
Exactly. So, but like I said, culturally, people grew to see that this is what happened with my grandparents, my parents, and they just follow. So, but if you, the story might not be the same when you're in places like Abuja, in Lagos, where you see men carrying the handbag of their wives, and the woman, you see her obviously happy and things like that. But the issue is, even the women in the rural communities where these men don't follow them, they also see it as normal, and they might not see anything wrong with it. It's us that are on this side of the divide that are thinking that, oh, if the man does more, it will help in the outcome.
Okay, as a gynecologist, Dr. Saidu, I know that skilled birth attendance has improved drastically. I'm talking about 86.3% over time. But we still have quackery in the system, which affects the life of many in rural communities. How is the ministry, bridging that gap?
All right, we need to say some facts that we have shortage of human resource for health. Then, even the one we have significant maldistribution.
Yeah. Especially the ratio
exactly
as to the person.
Yes. So that's the absolute shortage we are talking about.
Yeah.
Doctor population ratio or midwife nurse population ratio, we are way off it. Then we also, even the ones that are available, there's maldistribution. Abuja and Lagos kind of clustered most of these doctors. And of course, issue of JACPA is something that we're all aware of. On a daily basis, people are moving, both nurses and midwives and doctors. So these people we are seeing, these quacks, are like filling the gaps. When you don't have the right person in place, then someone can easily, it's like leaving a house empty. That's when rats will start coming. But if you are living there, it's unlikely you see that. So, but we have regulatory bodies who are supposed to be checking this. And I think they are doing their best. However, they may not have eyes even in those rural communities, because I'm not even sure if they also have the requisite number of health workers that can get to those areas. However, the population, the community has to be part of this. They need to report when they see something that is not ideal. So, and that's how they can help the system to also get rid of people who are doing things they are not supposed to be doing.
Okay, with the 6 documents unveiled recently, do you see us reducing the prevalence of deaths from maternal mortality before 2030, achieving this goal? Is this feasible?
Reducing, yes. Achieving
the
goal, I can't say for now, because you're talking about, are you talking about 70,000 per 70,000 per 100,000, 70 per 100,000 life births?
Yes.
So I can't tell you we'll reach that. But
right.
To reduce significantly, when you are going to, maybe you are going to Wuse now, and it will take you 30 minutes to Wuse, and 25 minutes, you've not gone halfway. It may not make sense for you to say, oh,
I'll get there in 30 minutes.
Yes. Are we going to make significant progress? Yes, I think we can do that, especially with the innovations that are currently ongoing. Whether we'll get to that 70, I'm not too sure. And for you to even know that even those that crafted these goals or these targets, they also said for those countries that are starting from a very high level, 140 per 100,000 live births is a good achievement. So 140 per 100,000, that is possible, because as at the time these targets were set, we are among the countries that have very high level, over 420 per 100,000 live births. So
that's huge.
Yes, that's huge. So we think it's possible to get that level, but we need to sustain the momentum that is currently ongoing.
Can't we raise up to meeting this goal as a country?
We can. with the support of everyone.
You're very optimistic.
Well, for the media, we'll play our role
Yes.
by creating a sense of, creating a platform for advocacy so that every voice can be heard. Thank you so much, Dr. Saidu. I know there's a lot you want to share with us, and there's a lot we have to keep monitoring. The time frame for pregnancy is 9 months, so there's a lot to monitor to ensure that these documents, you know, are well implemented, especially across the hinterland.
Yeah.
Thank you so much for coming on platform. We do appreciate. He is an obstetrician and gynecologist and head Safe Motherhood branch from the Federal Ministry of Health and Social Welfare. Thank you once again, and keep up the good work.
Thank you for having me.
Our pleasure.
Thank you.
Elizabeth Omori, our vibrant health correspondent, one of them. Thank you so much for coming on platform.
Thank you for having me.
All right. And yes, we've been discussing ways to promote safe motherhood in Nigeria. No woman deserves to die while giving birth. And of course, when every aspect and everyone play their role and every aspect is covered and expanded, of course, access to quality maternal health care is guaranteed. And that's Platform. I'm Ruth Aguwele. Bye.